What should a clinician know about HCC staging? We all know that HCC is an aggressive tumor which occurs in the setting of cirrhosis. And usually when the patient comes to us, the diagnosis is late when the survival is 6 to 20 months. And there's a big interplay between the tumor and the underlying liver disease. Why do we need staging? It helps us in accurate prognostication. It establishes a common scale for selecting most appropriate treatment and compare outcomes at different centers. Identify patients for cures and identify poor outcomes. So in the case of HCC, what they have done is an integrative staging where they take into account the tumor characteristics as well as features of cirrhosis liver. So you assess the tumor characteristics by the size, number, tumor burden, invasion, venous invasion, extrahepatic spread, general condition like performance score, and liver status, whether the patient has evidence of chronic liver disease, what happens to the bilirubin, albumin, INR, and hepatic reserve. Just to briefly tell you what performance status is, 0 is when the patient is fully active, more or less as before illness, and performance status 4 is when the patient is in the bed or in the chair all the time and he needs complete care. And in between you have status 1, 2, 3. It's got very strong association with the tumor burden and the severity of liver disease. And we are all familiar with the cancer-related symptoms. The diagnosis of HCC is made by way of alpha-fetoprotein. Any value more than 400 is diagnostic of HCC, and more than 1000 is suggestive of an aggressive tumor. Imaging is very, very characteristic. There is a hypervascular pattern on arterial enhancement and a very rapid washout. And you tend to see the portal vein as well as the branch invasions. MRI is even better than CT scan, and it tells you whether the tumor is well differentiated or poorly differentiated. But I need to re-emphasize what Dr. Pankaj Puri mentioned earlier, that liver biopsy in HCC should not be done except in cases when the diagnosis is in doubt. Before going to the staging, I would also quickly revise the treatment options that are available to us. Resection is possible only if the patient doesn't have any evidence of clinically significant portal hypertension like varices, splenomegaly, HVPG being less than 10 millimeters of mercury, and platelets, if they are less than 1 lakh, patient has clinically significant portal hypertension. This is a contraindication to resection. And if you have better techniques like laparoscopy, then possibly a marginal increase in portal hypertension would help you in resection. But you have to keep in mind that there should be adequate liver volume left once you have done the resection. Loco-regional treatments, these may be partially curable or potentially curable. And if you can manage these loco-regional therapies, it will help you in improving the resectability. But usually they are indicated in lesions which are 2 to 5 centimeters, and the results are best when the tumor is 2 to 3 centimeters. Percutaneous ethanol injection is very good for lesions less than 2 centimeters with a good survival rate of 5 years, 50%. Radiofrequency ablation is even better. Smaller the tumor, better the results. 5-year survival has been reported to be 68%. Combination of radiofrequency and transarterial chemoembolization also gives fairly good results, although not very much advantageous to isolated frequency ablations. You have microwave ablation, which you can tackle a 5 centimeter lesion with a good survival rate of 75%. And at PGI Chandigarh, we have irreversible electroporation, which also has given very good results, although we don't have any 5-year survival results with us as yet. Transarterial chemoembolization is one of the most important therapies for managing HCC. Even though the 5-year survival is not very good, but at least 1 and 2 year survival is fairly good. And it is mostly used in unresectable HCCs. It's partially curative, but is very helpful in downstaging the tumor. And you have different types of transarterial chemoembolizations like conventional, depth TACE, balloon TACE, precision TACE. You can do the TACE repeatedly, but it is said to be refractory when you have done 3 sessions. And you should be familiar what are the contraindications for doing it. Any bilirubin less than 2 is fine. There should be no decompensation, and the creatinine should be less than 2 mg/cent. Beyond TACE, it is transarterial radioembolization, where you use yttrium seeds. It is also known as selective internal radiation therapy. The advantage of this is it is managed by way of similar to transarterial chemoembolization, but you can safely give it in patients with portal vein thrombosis. You can give it in tumors which are more than 7 centimeters in size. And studies have shown that large tumors have results almost the same as TACE. But for TARE, you can go only up to 1 to 2 sessions. And recently it has been shown that personalized dosimetry gives even better results. There is a lot of talk on stereotactic body radiotherapy, SBRT, for lesions less than 5 centimeters. It has been shown to be excellent. It improves the portal vein patency and response is very good. And lastly, you have systemic chemotherapy, about which Dr. Anand Kulkarni would later speak. Liver transplantation is curative. You have to pick these patients within the Milan criteria, which means 1 lesion less than 5 centimeters or 3 lesions less than 3 centimeters. Or you have even a more liberal criteria like University of California, San Francisco, where the survival is almost the same between the two, but you can pick up larger lesions. And downstaging is something which we should all know that with loco-regional therapy, especially TACE, TARE, and external beam radiotherapy, you can decrease the size of the tumor, make it less viable, and subject these patients for liver transplantation within the criteria which is advocated. So what are the different staging systems? We are all familiar with the TMM staging with most of the malignancies, but unfortunately, this doesn't take into account the portal vein invasion and the status of the liver. So TMM is not widely used in HCC. Okuda staging, which was done in 1984, did take into account the liver functions and ascites, but it hasn't gained popularity. It had its own disadvantages. Cancer of liver Italian program, again in 1998, improved upon and included alpha-fetoprotein into it. And this is the whole list of different stagings from different countries. None of them have been so much accepted as the one that I'm going to talk to you about, the BCLC staging. And in a small study which we conducted in the Department of Hepatology along with Dr. Deeman and Dr. Ajay, we found that CLIP, Tokyo, and BCLC stages were almost equal in the Indian setting. Now, what is this Barcelona Cancer Liver Clinic staging score? This was established in 1999. It predicts the prognosis and mortality of patients. It is the most widely used, although there is no worldwide consensus on it. It has been extensively validated, and recently it has been updated in 2022. Accepted by most of the societies, it includes performance status into the score, and also ALB score, which is something new to all of us. The albumin and bilirubin score, which has replaced the child's puke score. and including platelets, PLB is also considered to be better. It is you get a score with the help of a computer with the calculations I just mentioned. So BCLC 0 is very early stage when the tumor is less than 2 centimeters with preserved liver functions, good performance status, no vascular invasion or extrahepatic spread. And you can consider resection, which is almost as good as radiofrequency ablation or microwave ablation. And suppose for some reason it is not possible, you can go on to do TACE and TARE as well. But if the liver functions are bad when the patient is decompensated, these patients should be taken up for liver transplant. And these patients with small tumors have a very good survival. Then you come on to early stage, that is BCLC-C, where you have a solitary lesion, irrespective of the size, and it could be multifocal up to 3 nodules less than 3 centimeters, again, with preserved liver functions and performance score, no vascular invasion and extrahepatic spread. You can do radiofrequency ablation, microwave ablation, even you can do resection provided there is no evidence of portal hypertension and the remnant liver volume is taken care of. Or you can downstage the tumor and do the resection. And liver transplantation also could be an option in these patients. So you have all these parameters because the liver functions are good and the portal vein is not invaded, you can do any of these therapies in them. The most common that comes to us in clinical practice is the BCLC-B, which is intermediate stage. And this usually has multifocal HCCs with normal liver functions, no vascular invasion, extrahepatic spread. But recently, the 2022 BCLC has divided it into 3 subgroups. B1, when the alpha-fetoprotein is very high, and you may be doing downstaging in these patients, and the patient, suppose he doesn't fit into the expanded liver transplantation criteria. B2 is when the patient is ineligible for transplantation, but if he has preserved portal venous flow, you do TACE. And occasionally we come across patients who have infiltrative lesions, which is extensive involvement. Usually TACE is not successful and systemic therapy is helpful in them. Earlier on in B, it was basically you have to do one of the loco-regional therapies. Then you have advanced stage where the vascular invasion has happened and there is extrahepatic spread. Performance score is less. Patient is in Child's A. You have to adopt to the systemic therapy in these patients with first line, second line, and third line, which we all would discuss later in the talks. And systemic therapies are indicated when the lesions are more than 10 centimeters, multinodular, bilobar, have elevated alpha-fetoprotein and ALB score. And lastly, the terminal stage is BCLC-D, which is a very advanced stage. Patient has a Child's Puke score of more than 9. And if the tumor is within the transplant criteria, you do a transplant in these patients, but provided the performance status is better. But if the burden is beyond Milan or UCSF, then you have to give supportive or palliative care. So the new BCLC needs validation. They have also said that you strictly should not follow the stage. You can do migration of the treatment if there are other coexisting comorbidities, technical issues, or treatment failure. So you can do an advanced therapy in these patients. They have included liver transplantation following downstaging with the loco-regional therapies like TACE and TARE, and they have subclassified stage B into B1, B2, and B3. Although they are silent on combination of systemic and loco-regional therapies, bile duct invasion, proton beam therapy, and recurrent HCC in Child's score B. So this is quite a complex algorithm, which one can only go through with peace of mind, but I've already mentioned what in essence is there in this algorithm. And finally, I would say that staging in HCC prognosticates and tells you what treatment options should be given to these patients. Can I have the last slide? You've taken it out. And the options are available with us. And you have to correctly assess the liver function status and vascular involvement of these patients before any therapy is advocated in them. You have to assess the tumor characteristics, performance status, and we should know that BCLC is the most accepted staging available with us, and follow the algorithmic approach as much as possible. Thank you very much for your attention.